Blood Bank Guy Essentials 018.
That's actually a really interesting question, Joe, and it's one that I've asked myself before as well because, okay, so the data shows Benadryl and Tylenol doesn't really help, but who cares? While, again, Benadryl and Tylenol are not the most dangerous medications out there, they're not completely without side effects.
Hi, everyone. Welcome back to the Blood Bank Guy Essentials podcast. My name is Joe Chaffin. Before we get started today, I really just want to thank you enormously for your faithfulness in listening to the podcast. I look at the numbers, for example, for the last two episodes, episode 017 with Dr. Mark Fung talking about transfusion reactions, and episode 016 with Dr. Jeannie Callum talking about somewhat controversial indications and non-indications for plasma transfusion, and both of those have been among the most downloaded episodes I have had since I started doing this podcast in April. So thank you very much. I want to let you know that on the Blood Bank Guy website at bbguy.org, as well as on iTunes and Stitcher Radio, you'll find a large number of other podcasts on other topics, including topics as diverse as Zika virus and massive transfusion and patient blood management and platelet refractoriness, pediatric transfusion, and the very most downloaded podcast is an episode that I did with Dr. Rick Kaufman on the daratumumab effect. I just like saying that. It's really fun. Anyway, planning things like pathogen reduction, CMV, blood donor testing, and red cell transfusion indications before the end of the year. So I hope you'll stick with me. On today's podcast, my guest is Dr. Heidi Shafi from Kaiser Permanente, Los Angeles. She's my co-host for the Ask the Blood Bank Guy episodes, of which we have another one coming out next month, by the way. She's going to be discussing the very common debate about whether or not you should pre-medicate a patient before transfusion. There's been a lot of back and forth about that over the years. The routine use of acetaminophen and diphenhydramine, Tylenol and Benadryl before transfusion. And she has a lot of stuff to say to us. So without further ado, I'm going to give you that interview with Dr. Heidi Shafi. All right, as promised, I am very happy to welcome Dr. Heidi Shafi back to the Blood Bank Guy Essentials podcast. Heidi, welcome back.
Thank you for having me back.
No problem. This is a historic moment. You are the first person who's been on the Blood Bank Guy Essentials podcast more than once, other than me. And those of you that haven't listened to the podcast a couple episodes ago on transfusion-associated graft versus host disease, Heidi is my co-host on the episodes where we do Ask the Blood Bank Guy questions and answers. And again, just a reminder for those of you listening to this, don't hesitate to send in your questions because we look at them, we read them, and we'll definitely try to answer them on a future podcast episode. But let me tell people a little bit about Heidi because we kind of skimped on her bio during the TAGVHD episode. Heidi was raised in Los Angeles, and she went to undergrad at UCLA, medical school at Georgetown in Washington, D.C., and came back home to Los Angeles to do her clinical pathology residency, as well as her training in transfusion medicine at Cedars-Sinai Medical Center, which is where she and I crossed paths a few years back. After she graduated, she became board certified in both CP and blood banking transfusion medicine, and practiced pathology at Cedars-Sinai before she joined Kaiser Permanente last year. She is the medical director of the clinical laboratory at Kaiser Permanente, Los Angeles, as well as being the director of blood banking at the same hospital. So Heidi, I'm sure you've heard other podcasts that I've done, and you probably know what the first question is, and it's just this. A lot of people listening to this podcast are people that are trying to figure out what they're doing with their lives. And you're someone who obviously has made a commitment to and is heavily involved in transfusion medicine. So can you take us through a little bit of your journey? You don't have to go too terribly long, but just a little bit through your journey. What led you to transfusion medicine? What got you excited about it? And what is it that kind of keeps you going now?
Sure. Actually, my journey is, like many of the other guests, a lot of different things happened that led me to transfusion medicine. But the interesting is that I actually went into medical school wanting to be a pediatrician. That's what I was going to do. And fourth year of medical school, I rotated through pathology. It was mostly surgical pathology. And then there were maybe a couple of, noontime lectures during that month for the residents. about blood banking. And, I sat in because I was on the rotation and I had no idea, what they were talking about. But I was like, wow, this is kind of interesting. Maybe like I should go into pathology and do this, although I had no idea what they were talking about. And, I actually decided to, apply for pathology too. And then, I kind of got scared off. I thought, well, I always wanted to do peds. I really don't know anything about pathology other than this month-long rotation, which was amazing, but it was only a month. And I thought, well, maybe I should just stick with peds. And then, within the first couple of months of my intern year of pediatrics, I kind of knew that it wasn't the right fit for me. I love kids and I love my co-residents, and the program at UC Davis, which I attended, was an incredible program, and I still keep in touch with some of the co-residents, but I just thought it wasn't a good fit for me. So I thought, okay, I'll pursue pathology again. So I did go back to pathology again in my mind that I'm going to do transfusion medicine, having only listened to maybe 1 or 2 hours of lectures, which I didn't understand. And so I went to Cedars-Sinai, which, as you know, is well known for their transfusion medicine program. So when I rotated through the transfusion medicine rotation as a second-year resident, it really solidified my desire to go into transfusion medicine. I had really great mentors, Dr. Van Vakes, Sam Pepkowitz, Holly Mason, and of course, Ellen Clapper, who has been a true mentor to me and a great friend. And so it just really worked itself out. So I had this vision of becoming a blood banker without really knowing what it entails. But fortunately, my experiences as a resident were amazing. And so I decided to pursue the fellowship, stayed on. And of course, that's where, we met, and the rest is history.
Well, that's awesome. As you've gone into a little bit of a different kind of practice now at Kaiser, how has it changed, if it has changed, your feelings about transfusion medicine?
I still love it. Of course, when I was at Cedars, I was primarily transfusion with a little bit of coag. Here, I would say I'm like 50% or so transfusion medicine, 50% or so, the other 50% is the clinical laboratory. I still love it. I still get the most excited about the questions about transfusion medicine, the blood bank questions. I'm fortunate enough to be on like a regional committee with all the other blood bankers throughout Southern California from Kaiser. So we get to get together over the phone once a month for 2-3 hours and kind of talk about all the different issues in our hospitals. So I think that, I still think that's the best part of clinical pathology.
Well, of course it is. My gosh, why would anyone think differently? For goodness sake. Okay, well, thank you, Heidi, for that.
Sure.
That's awesome. I can tell you that you made the right choice. I am very happy to have worked with you and to continue our friendship. So, and
I think I've said this to the listeners before in the last podcast, like Joe Chaffin has been an amazing teacher to me and to a lot of other younger blood bankers and up and coming blood bankers. So I feel really grateful that our paths crossed, and I still have you as someone that I can call and I can text and I can ask questions, even though sometimes they're very, very silly or dumb questions.
That is absolutely not true, but we'll edit out the part about me being a good teacher. We'll just keep, no. Thank you. You're very kind. But today we're going to talk about something that's interesting, and I love this topic. This was when Heidi and I talked a while back. Everyone, we were thinking about a topic that we could cover that would really just kind of hit right in the practical zone. Something that we get asked questions about a lot as blood bankers, and maybe a little bit less now than we used to, but it definitely still is out there, and we still hear about it a lot. And that is simply the topic of premedication to prevent certain types of transfusion reactions. So that's our topic today. We're going to discuss premedication for certain types of transfusion reactions, and I really think you'll find it interesting. We'll hit a lot of, as I said, a lot of practical stuff, a little bit of theoretical stuff as well. But I'm excited for you guys to hear this. So Heidi, are you ready to go?
I am.
Let us rock and roll. So let us talk first about transfusion reactions in general. And this is not a transfusion reaction talk per se. We're not going to go into each and every transfusion reaction, but just can you big picture it for us? When we think about transfusion reactions, what are the most common ones that we see?
Sure. So historically, the most common type of transfusion reaction has been the febrile non-hemolytic transfusion reactions. And just to our listeners, I'm going to call this febrile reaction from now on because it's a mouthful to say the whole thing. But obviously, when I say febrile reaction, I am referring to the febrile non-hemolytic transfusion reactions and not all the other reactions that have fever as a symptom. Okay. So historically, it was the most common because it's due to the white cells that are collected along with the red cells that we collect and are in the product, and it's because these white cells release cytokines, and this accumulation of cytokines can lead to a raise in the temperature. However, over the last couple of decades, with the introduction of leukocyte reduction, which is done to remove white cells, we have seen a significant decrease in the rate of these reactions. And now it's been reported to be anywhere between 0.1 to 1%. And I know that's a large range and it just depends on the studies that you look at. Mm-hmm. But, even though it seems like, 0.1 to 1% isn't much compared to the other reactions, it's still, you're like, well, so it's really uncommon, 1 out of 100 or even 1 out of 1,000. But when you compare it to the other reactions, it's still common when you look at hemolytic transfusion reaction, which it's 1 in 76,000, or sure. Trolley, which again has a wide range. It's 1 in 1,200 to 1 in 190,000. That has to do a little bit with, probably under-reporting of Trolley, but there is a huge range, but it's still a lot less common than febrile non-hemolytic transfusion reaction. And then the other big one that we see is the allergic transfusion reactions, which constitute, people say 1 to 3% of all transfusion reactions. I've also read 0.4, 0.5 to 3% of all transfusion, of all transfusions lead to allergic transfusion reactions. And these are believed to be type 1 hypersensitivity. The mechanism is not completely known. It is believed that it is probably due to Ig antibodies in the recipient that act against the plasma protein. So it is often plasma containing products such as plasma itself or platelets that are more likely to cause ATRs. But, as many of you know, we transfuse a lot more red cells. So don't be surprised if a lot of your ATRs are actually seen in patients getting red cells, because again, red cells do have some residual plasma even after processing. Mm-hmm. So again, it is the other most common reaction that we see.
Okay, so febrile reactions and allergic transfusion reactions. Can you just summarize for us real quickly? And we don't have to go into great detail about this. Again, we're not trying to make this a transfusion reaction lecture in terms of the details. But I think it's important for folks to understand when we say a febrile non-hemolytic transfusion reaction, what are we talking about? How is that defined?
Sure. So febrile non-hemolytic transfusion reaction, we're classically talking about a 1 degree Celsius increase in temperature from baseline, or you can reach a temperature of like 38 degrees or 100.4 Fahrenheit. Mm-hmm. You could also have some chills and rigors that go along with it. There are times that you can have a febrile reaction, particularly if you're pre-medicated, which we're going to talk about later, where you don't see the fever, but you see the chills. And so that's classically when you do the work in the blood bank, when you do all the lab work, there is no signs of incompatibility or hemolysis. All you see is just this change in temperature along with some chills and rigors in more severe cases.
Gotcha. So you've got that change in temperature. Heidi, how quickly does that happen? Is it typically fast, or is it days or hours later?
It's quite fast. It can happen within the first few minutes, and it could happen anywhere up until the couple of hours after the transfusion has ended.
Good. Okay. So we've got that defined, and I think just to emphasize to everyone listening, it's super important. Something that Heidi said in there, you can't diagnose, Heidi's heard me say this a million times, she knows what's coming. You can't diagnose a febrile reaction without a workup. You cannot do it. It is impossible. The signs and symptoms of a very early acute hemolytic reaction can look exactly the same as a febrile non-hemolytic reaction. And I'm just warning you, don't let me ever hear about any of you listening. Don't let me ever hear about you diagnosing one without a workup, or I'm going to come and find you. I promise you that. Wow, I sound scary, don't I?
Yes, you do.
I think I've threatened you with that before, have I not?
I think you have.
Okay, so I'm sorry. I'll take off my angry hat, and let's go back to the allergic transfusion reaction.
Okay.
And you described it, so again, tell us, what does that look like in a patient?
Sure. This is, where the patient has hives, just generalized itching. Sometimes it can be localized itching. That's more of a mild allergic transfusion reaction. Mm-hmm. It can get quite severe. They can have shortness of breath. In worst case scenarios, it can be a very severe anaphylactic reaction. Mm. But generally, what we see with allergic transfusion reactions, this rate of 1 to 3% of all transfusions, we're talking about the mild allergic transfusion reactions, which are often manifested as hives and itching.
Okay, so is that when we say allergic transfusion reactions, does that include the whole spectrum all the way up to the so-called anaphylactic reaction, or is it just those mild ones?
No, it includes the whole spectrum, but we more common, we see the common ones commonly.
Okay, got it. So again, in terms of the timing, does that occur early in the transfusion, late in the transfusion?
Early in the transfusion, Joe, and sometimes these can happen extremely early, within the first few drops. If someone is severely allergic, particularly if it's in cases of, IgA deficient patients, for example, who get a plasma component that has IgA floating around. These can be very early, very severe.
Okay. So let me throw this at you. So I think that blood bankers for forever have thought about these two reactions, the febrile non-hemolytic reaction and the mild allergic reaction, or the ATR, as kind of like, so what? Big deal. Whoopee-doo. So they got a little fever. So they got a little, some hives. What the heck is that an inaccurate reading of how significant these are to patients?
No. Well, let me put it this way. These are not insignificant to patients. They're generally, yes, they're benign. They're not, generally, they're not life-threatening, but they can make patients quite uncomfortable. Yeah. And, a patient who has severe itching, who is breaking out into hives, who has chills, they're uncomfortable. And typically patients who are getting transfused are very sick. They are dealing with a lot of other procedures, a lot of other medications that are taking in the hospital during that hospital stay, or they're cancer patients who are coming in on a regular basis just to get transfusion because they're on chemotherapy, they have pancytopenia. So this transfusion is really a part of their healthcare maintenance. And imagine, you're dealing with a lot of other confounding factors, and here you're trying to get a transfusion, which is supposed to be a very benign event, and you're experiencing chills and fevers and reactions, and they can be scary to the patients as well, because yes, typically they are benign and not life-threatening, but imagine you're getting this blood product, you're getting a product that's from another person infused into you, and your body is reacting to it. Yeah. It's not, even psychologically, that can be quite disturbing to a patient.
Wow, that's so true, isn't it? And I guess that kind of goes to what we're talking about today, in that, clinicians, if you put yourself in the shoes of a clinician, you did that for a while. I did that for a tiny little while as well. If you're a clinician and your patient is kind of freaking out about this for understandable reasons, you're going to sit there and go, wow, I'd really like to do something to keep this from happening, right?
Exactly.
That's kind of where this whole thing comes from. So let's circle back, Heidi. You mentioned several reactions. Obviously, it seems like we're focusing on the febrile and the allergic transfusion reactions. Is that because our topic today, premedication, are those the reactions that premedication has traditionally been thought to be useful for?
Yes, Joe. Those are the two that for which we've been using premedication. We still use premedication for, because those are the ones that we have premedication for. So let's we have Benadryl or diphenhydramine. That's the first generation antihistamine. That's what we use for allergic transfusion reactions. Now, it definitely can help in treatment of mild allergic reaction, and historically it's been used in hopes of preventing mild allergic transfusion reactions. It is a non-selective, histamine blocker, and we'll talk about that a little bit more later. And then we also use Tylenol or acetaminophen, which is used for the prevention of the febrile non-hemolytic transfusion reactions, and also used to treat febrile non-hemolytic transfusion reactions. So those are the two most common. They're so common that often in transfusion order sets that are like an electronic medical records, they're even built in. For example, in my current facility, and even in my old facility, they're actually built into the transfusion orders because they're so commonly used that the clinicians just have the choice to just click and, there you go, you have it. Some of the other options that we have what's called cetirizine or Zyrtec, and the reason why I wanted to talk about this is that, because as we'll talk about later, is that there are subsets of patients that may benefit from using premedication actually, although most of what I'm going to talk about today is to show that it's not very useful, but there are some small subsets that can benefit. And cetirizine is a second, unlike diphenhydramine, it's a second generation antihistamine, and it selectively inhibits the histamine receptor, and it doesn't cross the blood-brain barrier as does Benadryl, because Benadryl not only blocks the histamine receptors, it also blocks some of the other receptors that are in the nervous system, and because it crosses the blood-brain barrier, and it can cause unwanted side effects. Okay. So again, cetirizine is an option for prevention and treatment of mild allergic reaction. And then finally, corticosteroids. Again, these are used to treat moderate to severe allergic reactions. Like for example, when we talked about a patient who's getting a plasma-containing component and starts having shortness of breath and gasping for air, most likely a little bit of Benadryl or Zyrtec is not going to help them. They're going to need something stronger like a corticosteroid. Prevention as well, perhaps in patients who have had a history of severe allergic reactions. Again, if you're worried, corticosteroids are more likely to be your friend than something like Benadryl or Zyrtec.
And generally speaking, when we think about steroids, we're not thinking about something that's going to have an immediate impact, right? That's
Exactly. And, sometimes you have to dose it a little bit further out than you would do with something like Benadryl or Tylenol.
Okay. So we've got these reactions that we shouldn't discard as being bland and boring and benign because patients get upset about it for obvious reasons. You've got clinicians who are hearing about it from their patients who are saying, I want to do something. And you've described the main options. Certainly, I agree that the combination of diphenhydramine and acetaminophen is the most common premedication regimen, I should say. And I see it as you do, built into order sets in a lot of different places.
Right.
So are there any statistics on how common it is, leukocyte reduction in the United States? Premedication is in the United States?
So I've seen it quoted as anywhere between 50 to 80% of all transfusions.
Wow.
So that's, that's quite, that's a lot. So you would think out of every 10 transfusion recipient, 5 to 8 are getting pre-medicated.
Well, it has to work then, right? If that's what's going on, then it has to work.
Exactly, it has to work. Unfortunately, while we know that for treatment, these medications do work. For example, if someone is febrile, if you give them Tylenol, you're probably going to decrease that temperature. And if somebody is itching and has hives, if you give them some Benadryl or some Zyrtec, they're probably going to have some relief. But for prevention, most of the data out there hasn't shown that it works. And there are quite a few studies. So you let me know when you want me to start rambling on about some of the studies.
Well, let's do that. That's great. Let's talk about some of the studies. I mean, so everyone will know, you don't have to memorize these or write them down necessarily. We'll have these studies listed on the show page in the Blood Bank Guy site.
Right. I have some tables that I will, that Joe will be posting. It'll be, some of the common premedications, their mechanism of action, some of the, studies, and, also some references for further reading for it. Everything that we're going to talk about here today is from a published article. So you'll have all of that to look up.
Excellent. So just hit the highlights for us, Heidi, in terms of what's been published out there on premedication and its effectiveness in preventing allergic transfusion reactions and febrile reactions. What do we have?
Okay, so I'm going to go over the studies that were done in the last 2 decades, starting from 2000. The first study was from Patterson et al., and they looked at the role of premedication and leukocyte reduction on the rate of febrile non-hemolytic transfusion reactions pertaining to transfusion of platelets. And Joe, they showed that there was absolutely no difference. Premedications really didn't help. A couple of years later, Wang et al. Did a prospective randomized controlled trial, and that group looked at acetaminophen and diphenhydramine as premedication for platelet transfusions again. And what they showed is that when they looked at the pre-med group and the placebo group, again, there was no difference in the rate of transfusion reactions between the two groups.
Got it.
And then couple of years, I think after that, Sanders et al. Did a similar study. They looked at a prospective study where they looked at pre-medication with acetaminophen and diphenhydramine for transfusion of all products, not just platelets, and also in pediatric patients. They studied all the products, and they know when they compared patients who were getting pre-medication compared to those who hadn't, whether historically or concurrently, there was really no difference again in the transfusion rate of transfusion reactions. There was an abstract published a few years ago, which had a large number of transfusions, over 300,000 transfusions, and it included all products, red cells, platelets, and plasma. And again, looked at pre-medication with Tylenol and Benadryl, and they showed that it did not significantly affect the rate of febrile and allergic transfusion reactions. And then in 2000... You
said 300,000? That's a big...
300,000, yes. Huge. And unfortunately, they never published the study. I'm not sure why. But you can find the abstract, and we'll have that in our references. And then about 2008 or so, Kennedy et al., they did a prospective randomized double-blind controlled trial of acetaminophen and diphenhydramine, again, similar to Wang et al.'s study. But this time, they looked at both red cell transfusions and platelet transfusions. And so they concluded that looking at transfusion reactions as a whole, there was no difference between the two groups. The placebo group versus the pre-med group. When they broke it down and they looked at just allergic and just febrile, they noticed that in febrile, in patients who got acetaminophen and had leukocyte-reduced products, there was a slight benefit towards pre-medication for prevention of febrile non-hemolytic transfusion reactions. And then finally, there was a huge review, one of these Cochrane database reviews that looked at, both the Kennedy study that we just talked about, the Wang study that we talked about, in addition to another study that was done in 1992. It's in Chinese, so I couldn't get the full summary for the audience, but I will have it again in the references for anyone who is able to understand Chinese, so you can look at it. But they looked at these 3 studies because they were all randomized control studies.
Right.
And the bottom line was that there is really no significant difference on incidence of febrile reactions and mild allergic reactions. And of course, like any good review would suggest, they did say more studies need to happen.
Naturally, yes.
Exactly.
Well, I'm sensing a theme.
Yes, exactly.
Yeah.
it doesn't seem like premedications work.
It does not seem like it. And I know that you'll mention, I think, at least one other article later. I know the folks at Johns Hopkins have done a significant amount of work on this as well. And
exactly.
Their data is showing exactly the same stuff. And again, we'll have all those references on the site. But so, I mean, I think it's pretty clear that we've got something that clinicians want to do, but unfortunately doesn't seem to be doing what they're hoping it would do. So we've got this scenario where we're primarily seeing people getting acetaminophen, diphenhydramine routinely before transfusion in a lot of cases. Certainly not every transfusion, but in a lot of cases. And it doesn't seem to be doing a whole lot. So I guess my question for you, Heidi, is why should we care? So what? So they're doing something. It doesn't seem like it works, but is that a bad thing?
That's actually a really interesting question, Joe, and it's one that I've asked myself before as well. Because so the data shows Benadryl and Tylenol doesn't really help, but who cares? I mean, it's a little bit of Benadryl, it's a little bit of Tylenol. I mean, it doesn't help, but it makes the clinicians feel a little bit more comfortable with a transfusion. And, historically, I think that's why transfusion premedication has really taken off. Is because since the 50s, physicians always wanted to, of course, make the patients more comfortable. And, they would give antihistamine. Initially, they started injecting it into bottles of blood, and then over the years, it developed into oral medications, and now, like we talked about, it's built into order sets. And I think they think that it helps, but we've kind of proved that wrong. But the second, they think, well, it's benign. But the problem is, while again, Benadryl and Tylenol are not the most dangerous medications out there, they're not completely without side effects, particularly Benadryl. As I mentioned earlier, it does cross the blood-brain barrier. And when it does, it can cause cognitive impairment, dizziness, sedation. And so you can just imagine an elderly patient who's admitted with, MDS, needs transfusions. And so you give them a unit of red cells, and they're somewhere in their 80s, already impaired, probably because of their underlying condition, and then you add some Benadryl into the mix prior to transfusion, that an increased risk of falls and other events that may occur that could have been prevented, particularly because there's no benefit from it.
I see.
And so I think Benadryl, it's not, as benign and as everybody thinks. And then in terms of the antipyretics, such as acetaminophen, and I apologize to the audience. I know I keep jumping from Tylenol to acetaminophen and then Benadryl and diphenhydramine, but you all know what I'm talking about.
They can hang with you. They're a smart crowd. No problem.
Okay. So, I think the main thing with antipyretics is that, yes, Tylenol, its chronic use can, lead to liver damage. We all know that. But, we're talking about low doses, anywhere between 500 to 625 milligrams. Or 650 milligrams. But we're more worried about is that, it could mask reactions that are clinically significant. Because, as we talked about earlier in the podcast, this is the febrile non-hemolytic transfusion reactions, but hemolytic transfusion reactions can have a febrile component. And often that may be one of the first signs. And, things like Schwally, which are quite significant, can be, one of the first signs and symptoms can be, again, a fever. So, there is this thought that if you're giving antipyretics for something that doesn't really help with, not only it's not helping with preventing the febrile non-hemolytic transfusion reactions, you may also be masking that fever that may be your first hint at a more significant reaction. I
see. I might argue that that's probably more a theoretical.
Exactly, it is more theoretical. It is, yeah. And just like there's also some folks that say we should look at the cost effectiveness of premedication. Again, it's more of a theoretical. Sure. I think there was a group actually that published a study in Archives of Pathology and Lab Medicine in 2004, and they said that they really couldn't make say that there is a definite cost benefit or implication for healthcare providers to pre-medicate or not to pre-medicate. So their conclusion on that wasn't, it was very inconclusive. But, they talked about things like, well, when you, of course, pre-medications, they're not that expensive, but, causing a fall that may prolong hospital stay, that could be quite expensive, both to the patient and to the hospital. So, but again, those are theoretical too. So I think the main thing to look at is that, something like Benadryl, which can overset a patient, it can lead to increased morbidity and inconvenience.
So, I mean, maybe I could summarize it this way, Heidi, and correct me if I make this too simple, but if you've got something that doesn't help, and we know it doesn't help, essentially in all situations, granted the little bit of evidence in the one study, but for the most part, we can say it doesn't help, and it has potential to harm, even though we don't know for sure that it would, then why do it, I guess, right?
Exactly. It doesn't help, and it may cause some harm, so why do it? Exactly.
Yeah. Okay. Well, so with that being said, and I guess the question comes. We've talked about routine pre-medication, but are there any situations where you might want to consider it? I mean, or is it just a no-go, never, never, never kind of deal?
Okay, so never say never, Joe, because there have been some studies, particularly one that I can talk about, which has shown that there may be a role for Benadryl in recipients of platelet transfusions who have had allergic transfusion reactions. This particular group looked at transfusion recipients of, again, platelet transfusions. And what they noticed is that the majority of platelet transfusions that led to reactions happened in a very small subset of patients. When they concluded that, historically, as we've talked about, we've always said it's the plasma proteins of the donor that are floating around that cause this reaction in the recipient. But they said, well, if the majority of reactions are occurring in a small subset of patients, there's probably a patient factor too. For example, some patients might be more atopic. They're just more prone to have allergic type reactions. Yeah. And they, based on that study, a lot of folks out there have said, well, if we know a patient has had a previous reaction and they're probably then more likely to have another reaction, why not pre-medicate? Now, my argument against this practice is that it's okay to do it, but let's do it for the right reason, because the data overwhelmingly has shown that it doesn't help prevent allergic transfusion reactions, for example, giving Benadryl.
Right.
So, but yes, there are patients that are more prone to get reactions. So maybe pre-medicate, not in hopes of preventing the reaction, but perhaps alleviating the reaction, making it a little bit less intense, making the experience a little bit more comfortable for the recipient.
I see. Targeting more patients who seem to be more at risk, in other words. Exactly.
And again, this particular study that was published in 2011 in Transfusion focused on platelet transfusions and allergic transfusion reactions. As we talked about, there was a small, Kennedy et al. In their study did show that maybe pre-medication helps with febrile non-hemolytic reaction if it goes hand in hand with leukocyte reduction. So again, something to think about in that population. There was also another study that I didn't list in the table that I have you're going to be posting on your site, Joe. There was a study again in Archives and Patent Lab, the one that kind of was inconclusive about cost. This study actually concluded that in the group of patients that received pre-medication, there was less febrile non-hemolytic transfusion reaction than those who didn't. But what they did, there was no control group. They looked at a historical rate of transfusion reactions, historical reported febrile non-hemolytic transfusion reactions that were in the literature. And then they looked at their own practice, which was pretty much like universal pre-medication. And so they compared their data to what was in the published data, and they said, well, we pre-medicate universally, and therefore we have less transfusion reactions than what's been published prior to our work. Therefore, pre-medication can help. Mm-hmm. And they also concluded as part of the study that pre-medication, there is no evidence that dangerous transfusion reactions such as acute hemolysis, septic shock, or TRALI are masked by antipyretics.
Yeah, and that's kind of what we were getting at before, it's a theoretical risk.
Theoretical, right.
I have a hard time believing that someone in a full-blown acute hemolytic reaction I think they would laugh at the little bit of Tylenol that was in there, right?
Right, exactly.
Okay.
And then the other group, I guess it would be like the large volume exchanges, such as the red blood cell exchanges or plasma exchanges. Again, not because they necessarily prevent it, but perhaps they make the patient a little bit more comfortable. If we're talking about a sickle cell patient undergoing a red cell exchange, they're getting 10 to 12 units of red cells. That's a lot of both, cumulatively, a lot of plasma that is going to be part of that. So that could lead to allergic transfusion reactions. And even though we leukocyte reduce, there is still some white blood cells. And when you add 10 or 12 units together, that can be a significant amount. And again, it's the same idea for patients undergoing plasma exchange. You're removing their entire plasma volume, replacing it with plasma, all these proteins and allergic components that could, affect the patient, a sensitized patient.
All right, so I think we've got the message pretty clearly that in routine situations, pre-medication does not work very well, and that there may be some disadvantages. And you've outlined for us a couple of cases where you should consider it. But let's go back to the patients that we were talking about in the beginning, that are freaking out about having these reactions, and clinicians want to do something, and we've just taken something away, telling them, it just really doesn't work. So what can we do to prevent febrile non-hemolytic reactions and to prevent allergic transfusion reactions?
Okay, so Joe, as we talked about, leukocyte reduction really is the key to decreasing febrile non-hemolytic transfusion reactions. It really did decrease the rate after it became sort of like universally accepted. Mm-hmm. So that's definitely the number one alteration to blood products that you can do in order to decrease the rate of febrile non-hemolytic transfusion reaction. Okay. In terms of the allergic transfusion reactions, well, again, we have to think about the etiology. We talked about how the actual immunology of it is not 100% known, although we think it's an IgE-mediated process. But we do know that it has to do, at least in part, with the plasma and the proteins that are in the plasma. So you would think the less plasma, the less likely the recipient is going to have an allergic transfusion reaction. Right? So what can we do to reduce plasma? Well, we can wash products, right? So if we have a platelet product, we can wash it. Mm-hmm. But as you know, washing, you probably will lose, about 20% or so of the platelets. It does, it's not, we can't immediately do it. The centers that have washers in-house, it still takes about an hour, 30 minutes to an hour per unit. Those that don't have a washer, they have to send it to their blood providers to get it washed. Mm-hmm. So it does delay care. We do lose some platelets, but again, we do decrease, the plasma. Yeah. But we can wash plasma.
That would be silly.
That's always the issue. With platelets, I think, reducing the plasma, it's great. And an alternative to, again, volume reduction, essentially, again, decreasing the amount of plasma. And then the other emerging sort of alteration to blood components is platelet additive solution, which currently I think the one that's FDA approved is Intersol. I mean, you know much more about this than I do. And, it's about 65% less plasma than,
There are two, actually. It's not just Intersol, but Isoplate as well. Both are approved in the United States.
Perfect. And so, they're both about 65% less, correct?
Correct, yes.
And so again, and there has been actually a study by Cohen et al. That was published in 2014 in Transfusion, and they did show that there is a decrease, a significant decrease in rate of allergic transfusion reaction, and surprisingly, febrile non-hemolytic transfusion reaction. So this supports some of the prior suggestions and hypotheses that plasma reduction or, washing, etc., may help with febrile non-hemolytic transfusion reactions. The authors of that particular paper, they do leave it open-ended. They're not 100% sure exactly why this is happening, but they do say, for example, possibly if you have less, if you're removing plasma, if there's less plasma, well, there's less cytokine release because perhaps you need that plasma in order for the white cells to release more cytokines. One of the other things that they suggest is that, in addition to cytokines, febrile non-hemolytic transfusion reactions, may be due to donor antibodies that come along with the product, when obviously those antibodies are proteins and they're in plasma. So if you have less plasma, you have less of those antibodies as well. So, they do mention a couple of different theories of why there was also less febrile non-hemolytic transfusion reactions, but they're not quite sure exactly how mechanistically this has happened. But the good news is that PAS does show to reduce transfusion reactions, the two common ones that, we pre-medicate for. So that might be the wave of the future, in at least for platelet transfusions.
It might be. And I mean, the bad news, unfortunately, is that it's not widely, that product, platelet additive solution is not widely used yet.
Exactly.
Yeah. I think it varies by different parts of the United States, but basically the blood center, it's not just something a blood center can just say, okay, we're doing this today. It requires some modifications, adjustments to your apheresis equipment, and it's not just an incredibly simple process, but it's not the hardest thing in the world either. But I would say that right now, a minority certainly of centers are making platelets using the platelet additive solution.
Right. And so, at least there's some things that may be on the horizon. But again, what do you do with the red cells that lead to some of those transfusion reactions? Other than, of course, we talk about leukocyte rejection, but, I see a lot of allergic transfusion reactions with red cells. And then also, what do you do with plasma?
Yeah, that's the struggle. That's the struggle. Unfortunately, it doesn't seem like we have that many great answers yet. And perhaps, Heidi, you mentioned this before. Once we have a better handle on the actual etiology of this and exactly why allergic transfusion reactions happen, we know that they're more complex than we've thought. That's for sure. But once we've really nailed that down, maybe we can come to some better solutions for the non-platelet products where we can, we know that getting rid of some of that plasma helps.
Right, and that's the hope. But meanwhile, I think what we need to do is just, at least as a pathologist and as blood bankers, is to educate our clinician colleagues who are actually on the front lines and, transfusing patients, to let them know that the data overwhelmingly does not support premedication. Premedication does not seem to prevent transfusion reactions, and that, it can cause, some harm, particularly Benadryl. So if it's not helping your patients and it's not, it may put them at, harm's way, then why do it? And then, also let them know there are certain, things that we can do. If a patient has had a severe allergic reactions or even a moderate allergic reaction and it's repeated multiple times, we can talk to them about some of the things that are available to us, such as volume reduction and washing. Right. And in terms of febrile, I think many of the hospitals currently are transfusing leukocyte reduced. So if that's not helping a particular patient, unfortunately, we don't have a whole lot to offer. Other than that, there is some soft data out there that in patients with patients with a history of a febrile reaction, possibly, acetaminophen can help, at least to help them be more comfortable.
Yep. Well, I think that you're right on with that, Heidi. This has been a really great detailed look at this topic, which quite frankly is deeper than it appears at the beginning, isn't it? There's more to it than just don't do it, do it. It's a bigger decision than that, I think.
Right. I mean, because I think ultimately we all want to take care of our patients, and we want to make their medical care as as pleasant as possible. You know, I mean, medical care is not pleasant, so whatever we can do to make it more comfortable. It's our duty to do that. But,
Agreed.
We also don't want to do things that may cause more harm than good.
Absolutely. Well, Heidi, this has been great. I really can't thank you enough. I really appreciate you taking the time to hang out with me today. I look forward to the next time we get together for another Ask the Blood Bank Guy session.
Yes, I can't wait.
Yes.
I'm like, I want to ask the questions. I don't want to be the recipient of questions.
I didn't pimp you too much, did I?
No, not too much. Not too much. Not too much. But, it's still better for me to do the interview.
Next time. All right.
Okay.
Thank you very much, Heidi.
All right.
Hey everyone, it's Joe back in the studio with a couple of closing thoughts. I really want to thank you for listening. I hope this has been helpful to you. For some of you, I realized as Heidi and I were talking that you might be thinking, why is this an issue? Why are we even raising this? I think that among most blood bankers, most of us are pretty aware of the fact that premedication doesn't really help all that much. But I have to tell you, among many clinicians, not all, not by any stretch all, but among many clinicians, it's actually pretty common still. I actually see it a lot in hospitals that I work with, when I go out and I look at the transfusion order sets that physicians have set up in the computerized physician order entry systems, the CPOE systems, the electronic medical records. It's not that uncommon to see routine premedication before transfusion, and it really just, as we've said, it doesn't help all that much. So again, I hope this gives you some data and some ammunition. If you'll take a look at the Blood Bank Guy website, bbguy.org, click the podcast button, and you can find the show page for this episode 018, where all of the references that Dr. Shafi went over during her talk will be there on that show page. One more thing that I do want to mention, this is specifically for pathology residents and trainees. I am working on something that is really designed just for you. It's a brand new, completely flexible, stay-at-home way to master blood banking and transfusion medicine, as well as prepare for your standardized exams. I think most of you are aware that I have an over 20-year history of working with pathology residents and preparing them for the transfusion medicine portion of the standardized exams that you guys have to take. I have something that I'm very excited about. I'm not quite ready to share all the details yet, but I hope that you'll take just a minute right now to go to bbguybootcamp.com. That's bbguy, BOOTCAMP.com, not .org. And there you can just sign up for a completely no obligation, no spam interest list, and I'll just share the details with you on what's going on coming up real soon. I hope that you'll let other residents in your program know about it, spread the word around. It's something that I really think will be beneficial for you. If you're not a pathology resident, by the way, I have some other things coming real soon that I'm working on, so stay tuned. So that's it for today. I really appreciate you listening. Until next time, as always, I hope that you smile. I hope that you have fun. And above all, never, ever stop learning. Thanks a lot. We'll catch you next time on the podcast.